This session, we are happy to have Professor from Fu-Tsai, Professor Gong, at the first speech. Professor Gong is the past president of HEMI and past department chair in Chang'an Memorial Hospital, Kaohsiung. And he is now the professor of Chang'an Memorial University, Chang'an University, and still the standing director of TSRM. And he will share his view and experience about the surgical management of endometriosis, especially stress on how to spare and preserve the ovarian function. It's very important for patients with fertility desire. Professor Gong.
Thank you. Thank you for Mr. Chen, so kind introduction for me. And I also particular thank to Professor Ichiro for his long-term standing supporting me and encouraging me and giving me such a wonderful opportunity to present this topic. I want to tell you how to preserve ovarian reserve in surgical management of ovarian endometrioma. There will be 5 small parts in my talk. We all know that there are 3 laparoscopic techniques in surgical treating the endometrioma: simple drainage, cystectomy, and aberration. We have known that simple drainage is not allowed or is considered to be an appropriate method to treat endometrioma because we leave the endometrial lesion inside the capsule. This is not aberration. And if we compare cystectomy with aberration, I would say that according to evidence-based medicine, evidence-based medicine in Cochrane data library, it's clearly shown that the cystectomy is superior to aberration in terms of recurrence of dysmenorrhea, dyspareunia, and non-cyclic pelvic pain and endometrial recurrence. And another important issue is cystectomy will result less requirement of further surgery after recurrence. And surprisingly, that there is a higher spontaneous conception rate in systemic group. So overall, we can see cystectomy win. And how can we perform the good cystectomy? This is my experience, my principle. I will tell you that first we got to realize the adhesion around the endometrioma to mobilize the ovary and make an incision on the ending mesovarian border along the ovarian axis, and make so much effort try to keep the incision far away from the hymen. And during the procedure, we got to minimize the vessel destruction. I mean, to avoid the unnecessary blood vessel laceration. And finally, we restore anatomy. I like to tell you this photo. You can see that the endometrioma should be dedicated, finally excised or removed from the ovarian stroma. And when you look at the specimen, I mean the pure specimen under microscopic examination, you can see actually there is no follicle. There is no follicle around the specimen. That indicates my surgery is adequate because we never lose any ovarian follicle. This is very important for me. And how can we stop the bleeding on the ovarian stroma or so-called medulla? To choose the suture or to coagulate, according to the Dr. Kakano published in 2008. This is very small study, but it's interesting. This interesting tells us that compare the suture and the coagulation between the 2 groups. You can see the suture will result less chance of post-operative adhesion formation. the incidence is 30%. In the meanwhile, population will result in 57% of adhesion formation after operation. So I would say I will recommend breathe to the suture and intra-ovarian suture. Recently, systemic review and meta-analysis published in 2015 by Dr. Ada, published in JAMA. In terms of MH assessment, I mean, we monitor the MH level after operation periodically. It clearly shows that if we use the hemostatic agents such as tissue, whatever, it's much better than suture and better than bipolar dissection. This is in terms of MH drop after operation. This is my personal experience, my personal preferred procedure. This cartoon I show you in the beginning, I prefer to inject the so-called vasopressin solution around the cortex, try to reduce the ovarian diffusion in the ovary. It's optional use. And I make incision and incision by shallow blunt dissection. And then, of course, we remove the ovary, remove the endometrioma from the ovary. And finally, I start breathing by suture. Sometimes I use the bipolar population to start breathing, just for active breathing from the hyla, from the stroma. And normally, I don't populate the ovarian stroma or medulla. I try to make a suture intra-ovarian suture to start breathing, and finally, I will make a good approximation along the wound edge by using 2 to 5 suture material stitch. And finally, I put some hemostatic agents such as tissue inside the ovary. I mean, I try to avoid any kind of mechanical or thermal or bipolar injury on the ovarian tissue. This is extended endometrioma. And of course, I enucleate the endometrioma from the cortex. And I make the intra-ovarian suture interrupted. I try to stop the breathing. I try to close the open wound. And finally, I approximate the wound very carefully. Let me tell you, I try very hard. Don't put the suture material outside of ovarian cortex. Always keep suture material inside ovary, please. Why? Because as you may know, actually, suture material exposed on the ovary is one of the leading cause for post-operative adhesion formation. I would say that material exposure, suture material exposure is a killer of the ovary. Of course, finally, I got to do some procedure to prevent adhesion formation. I have a 5 step, as you may know, that the complete hemostasis. Again, good approximation and suturing. Less suture material exposure, please. And we got to clean the whole pelvis. Don't leave the blood clot inside the pelvis. And the optimal use of anti-adhesion agent. And of course, please avoid any kind of post-operative pelvic adhesion. Okay, we are very concerned about the pregnancy after the surgery, after ovarian cystectomy or ovarian operation. There are 2 nice papers. I would say this paper I appreciate very much. Published in the fertility sterility. You can see that on the left one. Okay, sorry. On the left one, you can see a very nice study published by Moderator in 2000 from Italy in 1998. It clearly shows that cystectomy will result in almost 65% of cumulative pregnancy rate 15 months after operation. In the meanwhile, aberration had almost 20% only. Let's move to the right one. You can see that a nice paper published by Aberration in 2004 from Iran. It always he always demonstrates a similar result. Look, cystectomy will result in almost 60% of natural cumulative pregnancy rate 1 year after operation. In the meanwhile, aberration only had almost 20%. This is very interesting. And 60% of the patients will conceive naturally after operation. On the other side, you can imagine that 40% of the patients after cystectomy still suffer from the infertility. What can we do? Everybody will say, go to IVF treatment. This is a very nice paper, I would say, published in 2015 by Professor Chapon in France. They try to understand, they try to evaluate what are the prognostic factors in determining ART outcome in terms of treatment efficacy after cystectomy. They find 4 factors will determine the prognosis of IVF treatment for those patients who had undergone ovarian cystectomy. They are APAGE level less than 2 nanogram per ml, antral follicle count less than 10, and any previous surgery for endometriosis with either superficial endometriosis or so-called deep penetrating endometriosis, and of course for ovarian endometrioma. That means if patient they need to go through the IVF treatment after ovarian cystectomy, and the major determining factor for this patient to succeed in IVF treatment, it should be a good AMH level and more AMH number, and no history of the previous surgery for endometriosis, either DID or endometrioma. Okay, what do you think when you look at my photo, bilateral endometrioma? I would like to mention this issue because bilateral endometrioma, the incidence is around 33%. I would say it's pretty high, but it's very common. But ovary, bilateral ovary, occupied or damaged by endometrioma is another disaster for ovary. What happened after we performed the cystectomy for bilateral ovarian endometrioma? I would say this is a very nice paper published in 2019. The author tried to explore unilateral cystectomy, bilateral cystectomy. Did they affect differently in terms of AMH drop after operation? It clearly shows that for unilateral cystectomy, the AMH level dropped by 39%. In the meanwhile, bilateral cystectomy will cause the AMH drop by 57%. The difference, a very obvious difference between the two. And how about natural conception rate after bilateral ovarian cystectomy? I'd like to study this paper because I think this study is very interesting. Dr. Basaka published in 2006 in the American Journal of Obstetrics. Their data tell us that the cumulative pregnancy rate 1 year after operation with bilateral cystectomy maintained 66%. It looks nice, right? Look, you can see the cumulative pregnancy rate here. But please be careful. There are 2.4% of the patients will suffer from complete ovarian failure. Okay. And another issue is recurrent endometrioma. We all know that endometrioma actually tend to recur at any time of our time, and the incidence is 21% at 2 years, 50% at 5 years, and without any identified causes. How about the? Okay, thank you. How about the reproductive performance after repeatedly laparoscopic surgery for ovarian endometrioma? Since this paper is quite interesting, published in 2009 by Dr. Messini from, I think, Italy. It clearly shows that this almost 20-something% of the natural conception rate, if you repeat laparoscopic ovarian cystectomy for recurrent endometrioma, So I would say that this is a pregnancy rate pretty low. For some reason, we are so much afraid of the ovarian surgery and the ovarian damage causing the damage on ovarian reserve. So we are looking for another surgical method. Here comes the sclerotherapy. Okay, we can aspirate endometrioma through vagina or by laparoscopy, and using the 95% ethanol. The most recent report from this year from Dr. Norton in the Genic, he said after 31 months of after a mean of 31 months of follow-up, the pregnancy rate is 57%. In the meanwhile, the recurrence rate is 9%. Two recently systematic reviews by Dr. Cohen and Dr. Gornakov said that the pregnancy rate by sclerosing therapy, the pregnancy rate is 20 to 57%, and the recurrence rate diverges very much, whereas from the 0% to 91.5%. And for this paper by Dr. Cohen published in 2017 in Fertility Sterility, the author recommended that this procedure and this therapy is good for patients with poor ovarian reserve. Of course, when we try to perform this procedure, we have to have a so-called good candidate selection, and we must exclude the possibility of malignancy or pre-malignancy for ovarian endometrioma. This is my personal post management flow chart. I always divide the ovarian endometrioma before operation and to rule out pre-malignancy or malignancy. And I always check the APAGE level in addition to CA-125. And I use the minimal invasive surgery to remove endometrioma by laparoscopy or robotic. And I emphasize a good surgical technique and optimal adequate use of hemostatic method to start the bleeding. For those patients who want to conceive, they are so eager to get pregnancy. I encourage them to try to conceive as soon as possible, and I ask patients return to my clinic to check out APAGE level, or sometimes including the AFC, intrafollicular count. If the patient fails to conceive 6 months to 12 months after operation, this will suffer infertility. Of course, I would advise patients to take a so-called assisted reproductive management. For those patients who don't want to get pregnant right now, I advise them to do so-called fertility preservation by taking the hormone therapy, or recommend to take a so-called social egg freezing. And I also recommend patients to check the energy level AFC regularly or periodically. Let's give you a real case. This 30 years old female, she suffered from infertility, and she had bilateral endometrioma and underwent the cystectomy. Before aberration, I checked her AMH level is 9.6 nanogram per ml. 3 months after operation, I rechecked the AMH level. AMH level went down to 42 nanogram per ml. It indicated actually this patient, in terms of AMH level, ovarian reserve become worse. So I encourage her to get pregnant as soon as possible. Lucky enough for her, she never conceived. She conceived spontaneously 6 months after operation. Okay, I would say laparoscopic surgery for ovarian endometrioma is so-called necessary evil. We had to balance benefit and damage on the ovary. Although it's able, but it's essential, necessary evil. And what we can do as a physician, I try to balance the two. Let's go to the conclusion. I emphasize that by doing the ovarian cystectomy during the operation, I make so much effort try to minimize so-called surgery-related thermal injury and the suture material use. Very often I frequently use the hemostatic agent to start bleeding. And finally, I will monitor ovarian result of the patient and advise patient to take action in time to help baby, to help their reproductive capability. Thank you for your attention.